Good morning, good afternoon, and good evening to delegates from all over the world. Warm evening wishes from India. I'm Dr. Praveen, and I will be chairing today's session on innovative approaches to improving primary healthcare. So before we go into the session, quick housekeeping announcements. So all of you can see a live Q&A text box to the right of your screen. The delegates, if you have any questions that you want to ask to the speakers, feel free to type in this box. The speakers will respond to these questions once all the presentations are over. There is also another box, which is the discussion forum. If you want to chat or if you want to discuss or comment on any of the presentation, please feel free to put that in the discussion forum. A point to note is that we will be responding to the questions that are in the live question and answer, and the discussion forum will be followed later. So now, before handing over to the speakers, I just wanted to quickly recap on why primary healthcare is important. And to summarize and quote the WHO report on the primary healthcare, this is critical for three important reasons. One, primary healthcare is well positioned to respond to rapid economic, technological, and demographic changes, all of which impact health and well-being. Two, primary healthcare has been proven to be a highly effective and efficient way to not only address the main causes and risk factors for poor health today, but this is also important in handling the emergency challenges that threaten health and well-being tomorrow. And no better example of this than the COVID environment that we are in currently. And finally, the stronger PHC is essential to achieving the health-related sustainable development goals and universal health coverage. This will also contribute to other goals beyond health. So with this small intro on the importance of primary healthcare, let me invite the first speaker for today, Dr. Della Berano from the London School of Hygiene and Tropical Medicine. Dr. Della will be speaking on embedding and scaling up the community-based newborn care innovation in the Ethiopian health system, lessons from evaluating a 5-year program. Dr. Berano, over to you.
Okay, thank you very much. So as said in the introduction, hold on. Yeah, so embedding and scaling up community-based newborn care in the Ethiopian health system, lessons learned from evaluating a 5-year program. So I am actually presenting on Dr. Bilal Ivan, who's unable to join us today. So as mentioned in the title, the study, this is done in Ethiopia. So Ethiopia has a population of about 100 million, and over the last 20 years has made great advances in key maternal and child health indicators, notably in under 5 mortality. But neonatal mortality over the last 15 years has remained stagnant, with about currently at 29 deaths per 1,000 live births. So in response to this, the Ethiopian government has launched the community-based newborn care program. So the community-based newborn care program has 9 components, and we see those images on the right side. Some of these components, the first 8 that I will be mentioning, are actually existing services. So in the antenatal period was the early identification of pregnancy. The second component was provision of focused antenatal care. Third component was promoting facility delivery. So then the perinatal period, there were 4 components, which included safe and clean delivery, immediate newborn care, including cord care. 6th component was recognition of asphyxia and initial stimulation. The 7th component was prevention and management of hypothermia. In the postnatal period, there were 2 components, which were the management of preterm and low birth weight neonates. And the last one, the 9th component, which is the management of neonatal sepsis or very severe disease at the community level. So for this 9th component, which as I mentioned is the newest component, health extension workers, which are community health workers, were trained to recognize the signs and symptoms of possible sepsis and provide gentamicin injection for 7 days and oral amoxicillin for the same amount of time. If referral was not possible. If referral is possible, they just provide a pre-referral injection of a gentamicin and oral amoxicillin and refer to the health center. So that was the new component of community-based newborn care. In terms of the implementation of what I will now call CBNC, community-based newborn care, it was done in 3 phases. In the initial phases, it was done in those darker green areas in the country. In the second phase, it was scaled up to the lighter green areas, and then lastly to the gray areas. The gray areas is about 10% to 15% of the population. So it started in 2014, and the gray part, scaling up to the gray parts of the map was in 2018. So if we move now to the evaluation of the program, just to give you an overview of what was actually done, we did a baseline survey in 2013 prior to the implementation of the program. We did a qualitative survey in 2014, a quality of care assessment in November 2015, and then a follow-up survey, which was 4 years after the baseline survey was done in 2017. In terms of the scope of where we went, again, we went to those 4 regions out of the 11, but they comprise about 80% of the population. So for the baseline and endline, we had 101 districts, about 206 health facilities and health workers. For the quality of care, which was done in 2015, we went to fewer districts, but sampled a lot more health facilities, 120 health centers, and the 240 health extension workers and health posts. And also we looked at the consultation of about 600 young infants. So in terms of the kind of study instruments that we used, for health extension workers who are working at health posts at the community level, we tried to assess their knowledge, supervision, their training, their capacity. This was done to clinical vignettes, and also we assessed their practice. At health center and health posts, we looked at record reviews, equipment, supplies, and the kind of support that they provide or they're provided with. And lastly, for the midline or the quality of care assessment, which was done in 2015, we also did an observation and consultation of health extension workers with sick young infants who were 0 to 59 days old. So now jumping into the key findings of this program, we looked at both the health system status and the quality of care. To sort of create a framework for the way we present the results, we used the WHO's community health worker functionality. We adapted that. And on the left side, where you see health system response, we tried to see, once community-based newborn care program was implemented, what kind of support did the program have? And also, when we say support, the kind of things we're looking at are drugs, infrastructure, job aids, etc. We also looked at the kind of linkages that were there, mainly looking at the sort of supervisory linkages and support that health extension workers were getting from higher level up in the system. And in order to see how this changed over time, we looked at the baseline and endline surveys, which were done in 2013 and 2017 to see what kind of changes were present. And then if you again now look at the right side, in order to understand the quality of care that was being provided by health extension workers, we looked at their capacity. And by capacity, we're trying to assess their knowledge or their understanding of some of the required steps they need to take when faced with sick young infants. And we also looked at their actual performance by observing their consultation of sick young infants, and then having those same sick young infants being examined by a gold standard re-examiner to see how well those two classifications matched. And these 2 green boxes that you see, this was done through the midline quality of care assessment, which was done in 2015. So now looking at the health system response to community-based newborn care, when I mentioned earlier system support, looking at drugs, equipment, and job aids. On the left side, you will see drug availability between baseline, which was at 2014, and follow-up at 2017. And here you see definitely over the course of those periods, availability of drugs increased for oral amoxicillin, as well as for injectable gentamicin. However, only 35% of health posts had injectable gentamicin at end or follow-up survey in 2017. If we look at equipment, there was also increases in clinical thermometer, which is what is needed for health extension workers to classify, to assess sick young infants, same as infant scale. So generally there was an increase for thermometer, but more or less the same for infant scale. If we then look at under the same box, system support, looking at job aids, there was also an increase in job aids chart booklet, which is the algorithm that they use in order to assess, classify, and manage sick young infants. There was an increase in the availability of that between baseline and follow-up, and similarly for registration books where they record their assessments. Now, the story changes a bit when we look at infrastructure. Things either stayed the same or did not improve, for example, for availability of water on the day of the survey. But also generally, you'll notice these things were not available even at baseline, and the situation did not improve. For example, electricity, only 1 in 5 health posts having electricity at more or less both time points. So now moving to that second box of the health system response, which is linkages. What we looked under linkages was supervision, again, looking at baseline and end line, in 2014 and 2017. What we see that about over 80% of health posts were being supervised, and this was in the last 3 months. However, when we dig deeper into the content of the supervision, what we noticed was that the health extension workers were getting a lot more support in that antenatal, perinatal period. A lot of the discussions covered institutional delivery, ANC, etc. But when we asked them if those supervisory visits included conversations on sick young infant management or that postnatal care components, very few health extension workers said that the supervision captured those discussions. So now we're moving at the quality of care. So now this is data coming from the quality of care midline assessment, which was done in 2015. So here we were trying to understand the capacity of health extension workers to deliver community-based newborn care. What we did is we provided them with clinical vignettes for the diseases that you see at the bottom. So giving them case scenarios of a child coming with a certain symptom, what would they do next? Then we'd tell them what those symptoms are. Given those symptoms, how would you classify them? And then once they classified, we'd say, how would you manage those? So it's a theoretical case scenarios. And we summed up those results and then created an index and then created cutoff points where we said, if they scored below, so from 0 to 59 was inadequate, from 60 to 74% was marginal, and then if it was over 75%, it was adequate. So you'll see that the illnesses that we assessed them for was diarrheal case management, possible severe bacterial infection case management, and again, for possible severe bacterial infection or possible sepsis, how they would follow up once they diagnose them, and then the last one being general well-being, advice on breastfeeding and hygiene. So what you see here generally is the red part. You can see almost half or a little under half of the health extension worker had inadequate capacity to manage these illnesses. In order to assess their performance, as mentioned earlier, we actually mobilized sick young infants from the community to come to the health post, where they would then have an entry interview. Then they would be assessed by a health extension worker. Her assessment was observed by a data collector, and then the same child would be re-examined by a health officer who was trained in management of this sick young infant illnesses, and that person or their diagnosis was considered to be the gold standard and compared against the health extension workers assessment or classification. So if you're looking at the results here, so again, as mentioned earlier, the clinical case classification using the integrated community case management chart booklet. And here we're comparing the diagnosis of health extension workers against the re-examiners, the gold standard, or which were health officers. So the 4 diseases that were assessed were local bacterial infection, possible severe bacterial infection or possible sepsis, NA dehydration, and jaundice. So when you look at their sensitivity and specificity, the main take-home messages here, they have high specificity, as you can see, over 90% for the 3 illnesses and over 80% for local bacterial infection. So this is good implications in that antibiotics are not being given wrongly. But then when you look at their sensitivity is quite low. It's 55% for local bacterial infection, 30 for possible severe bacterial infection, and then 45 for any dehydration. So another way of looking at this results is we actually combined all these 4 illnesses. So of all the sick young infants that came to the health post with these 4 conditions, how many of them were actually correctly classified? And it's 18%. So 8 and 10 were being missed, whereas 2 and 10 were being correctly classified. So just to recap and also have some final words on it. So CBNC program, which had 9 components, of which the 9th one was the newest component, management of neonatal sepsis or possible severe bacterial infection at the community level. So if you looked at the support, generally health extension workers had some of the drugs, not necessarily all of them. Some of the infrastructure was poor. Linkages, even though supervision was happening, it wasn't capturing the key components of the community-based newborn care program. In terms of capacity, relatively, they had inadequate capacity to manage the sick young infant illnesses. And this was further evidenced by the performance where we saw to only 2 in 10 sick young infants were being correctly classified. And then, in thinking of just overall summarizing things, I think community-based newborn care was an ambitious program, and I think the country succeeded in scaling it up in a relatively short time through the whole country. However, it's evident that the health extension workers need further support. And also, based on this evaluation and also other literature reviews, the government has also decided to reduce the gentamicin from 7 days to 2 days, which would also help the effort of the community-based newborn care program. And last slide is just acknowledgments. I'd like to thank the team and also just indicate that this work was commissioned by the Ethiopian Federal Ministry of Health. Thank you.
Thank you, Dr. Barano. So we will go to the questions after the end of the presentations. So this was a wonderful presentation on community-based neonatal-based care. So now over to our next speaker, Dr. Momina Muzammin. So she will be talking about leveraging an M-Health intervention to improve maternal health, empower women, and strengthen health systems in Afghanistan and Pakistan. Over to you, Dr. Momina.
Thank you, Praveen. Hello, everyone. It's a pleasure to be here. Okay. So I'm Dr. Momina Muzammin. I'm the research and M&A lead at Aga Khan University's Equity and Digital Health Resource Center. I'll be speaking about a research project of ours, which was implemented in select areas of Afghanistan and Pakistan since 2019, and the role it played specifically in improving maternal health outcomes, in empowering women, and in strengthening the local health systems. So just to give you a brief background of the challenges that exist in these health systems. We've seen that both of them struggle with poor monitoring and governance frameworks. There's a lack of transparency. So primary healthcare is mostly being delivered in vertical silos, and their different programs were essentially working towards the same goal, but there appears to be a significant disconnect between these programs. This ultimately leads to gaps in service delivery, and we see a lot of underperformance of health workers. And this is evident in the fact that these two countries are the only ones that still have endemic polio, and they have consistently poor MMRs, which is unfortunate despite considerable investment. So while there is a slight increase that we're seeing over the years, it's not nearly enough to meet the targets that are set out in SDGs. So we identified those, and then we selected certain areas in Afghanistan and Pakistan in a consultation with the government stakeholders. So remote and rural areas in these countries, they tend to suffer much worse health outcomes, and the same exists for gender as well. So we basically implemented this program in remote rural areas for a number of reasons. There's a lack of infrastructure there. There is a lack of quality healthcare. They're subjected to more natural disasters, a lot of political insecurity, and some religious extremism as well. So based on that, we looked at the scope that our digital health intervention could have, and basically combine that with the principles of primary healthcare that were defined in the Ottawa Charter to basically establish these goals for the project. We wanted to increase accessibility. We wanted to ensure that we're leveraging the right type of technology. We're working on intersectoral collaboration, as well as basically using different forms of health promotion. And what we wanted to do was ultimately improve health outcomes, specifically related to MNCH, reduce morbidity and mortality, and essentially strengthen the local health systems by improving their governance and accountability mechanisms, and the regulation and quality assurance, supporting the HRM, as well as ultimately improving the service delivery in the region. So our proposed solution, which is called Hayat, meaning life in Urdu and Dari, it's a multi-modular solution. It consists of a mobile application. The mobile app was provided to frontline health workers in these areas. And what it did was essentially simply digitalize all their operational activities. So whatever they were doing previously on paper registers, we digitalized that. But what that did was it gave us a large amount of data coming in, and we had this digital database from different frontline health workers in very good quality coming in to do continuous monitoring related to registries, personal and family health records, and it allowed the tracking of vital events such as antenatal care visits, due immunizations, and other events. The applications were also incorporated with BCC-themed awareness videos, and which had an underlying GE element to it as well. So the videos were there, and because of the remoteness of these areas, sometimes the health workers tend to experience connectivity issues. So they were able to synchronize the data through offline technologies. And based on the feedback that we got from the field, the scope of the application was further expanded to include human resource management, supply chain management. So we've kind of expanded it to create different versions of the application, working for different tiers in management and service delivery. So the data that we were getting from the application was then available on a centralized server, which was called the Hayat web portal. It was connecting various programs, and it was essentially developed for different programmatic as well as government managerial staff and other stakeholders. It allowed them to track health workers due to the GPS tracking technology that was present in the phone, to monitor their attendance, as well as making sure that they're going in the field when they're due to. It also made available close to real-time data, and it allowed them to access digitized reports on performance of health workers as well as their catchment areas. So monitoring and evaluation of the project was done through these main items. It was a quasi-experimental mixed method study. And what we did was the main quantitative method that we used was a household quantitative survey. And we calculated the difference in difference by looking at the performance of several MNCH outcomes in control and intervention areas at baseline and then end line. It was also followed by qualitative assessments, which included focus group discussions and key informant interviews, which were focused on the usability, interoperability, functionality of the applications to make sure that it was actually addressing the issues that were needed to be addressed. And then it was supported with continuous monitoring through the data dashboard, as well as field monitoring visits. So we recently completed the N-line survey, and we've yet to publish the results, but we've seen significant differences in these maternal health outcomes across the demand and supply. So we saw that due to the web portal, it seems that there was a significant increase in the number of health workers that were visiting households once per month. There were higher satisfaction levels. There was also an increase in antenatal and postnatal care provision, which was previously being avoided. It also generated a lot of demand when it comes to antenatal care visits, the tetanus injections during pregnancy, as well as iron supplements. Deliveries were being done more at health facilities in the presence of skilled birth attendants, and it also increased the postnatal, the number of women who were accessing or wanting to access postnatal care. And perhaps one of the most significant changes that we saw was the increase in women using family planning methods and the intention to use family planning methods in the future. So what it did was, in terms of strengthening the local health system, was strengthening the transparency and accountability mechanisms, like we discussed. We saw an improvement in contact and continuous coverage. There's a higher demand for services, higher utilization of services, and perhaps one of the most distinguishing features, which wasn't an aim going in, but which showed up, was the integration between different programs that we saw. So maternal health care was now being delivered in a seamless loop. For example, a lady health worker would register a pregnancy, and she would get continuous notifications on her phone whenever an antenatal care visit was due. And then there would be notifications going to the CMW. And once the delivery is done, there would be notifications going to the vaccinator or lady health worker to make sure that the child is vaccinated timely. So that was perhaps one of the biggest successes, because the horizontal integration that we've seen in the past presented a lot of challenges. And then for government stakeholders, there was the ability to, there's the availability of data to inform decision-making and effective resource allocation, which was particularly really important in the COVID-19 context. So the project had a very strong gender equality theme as well. So the health workers previously have reported very low digital literacy levels. And this is because of the significant difference between the mobile phone penetration rates in these countries between men and women. And they reported, due to the capacity building sessions and trainings, retrainings, they reported a higher level of they reported feeling a higher level of status within the community. They felt people listened to them more. They felt more comfortable relaying the information, and as well as the validity of the information. And then the awareness sessions were also unique, because it helped them relay information to a larger audience and create a larger impact. So previously, they just relay messages to the mother or the pregnant lady, but it seemed that there was a higher demand in the field to watch videos. And they were also more comfortable showing these videos to male family members who they were previously not comfortable doing that because of the conservative cultural norms. So what really worked for us in Hayat was early and continuous stakeholder engagement. We identified multiple stakeholders we were open to extending that list and taking on board whoever we thought whose policies and whose priorities aligned with our program, which was to ultimately strengthen the health system in these countries, especially maternal and newborn and child health. So the design was end user informed. There was continuous feedback coming in, and the technical team was always careful to incorporate it and as well as communicate once those changes were made. There was a huge focus on usability and capacity building of health workers. And so we made sure that the design was easy to understand. For example, the community health workers in Afghanistan, they don't necessarily have high levels of literacy, and they were more comfortable with pictorial forms. We made sure that the application had a pictorial format, which they just had to select. The applications were developed in local languages, and there were continuous training sessions throughout, which proceeded to become remote training sessions once the lockdown ensued in each country. There was also a continued focus on the end goal throughout the project, and going in, it had a very specific I think it had a very limited scope when we first went in, which was to improve immunization outcomes and perhaps improve ANC outcomes. But we saw the potential. There was continuous coordination with the donors who were open to modifying the scope and just ensuring that we take up whatever opportunity that shows up. And that proved really helpful. And then adaptability in COVID-19 context. So it was really interesting and very heartwarming to see how the application was used once there was a lockdown, people couldn't move around. The health workers were sharing awareness content, the government stakeholders. So they were sharing awareness content through remote means now. And government stakeholders were able to assign effective resources. So it was depending upon which areas had the most need. So the project currently, the government in Gilgit-Baltistan in Pakistan, the Department of Health has agreed to absorb the project in its national budget, in its provincial budget. And in Chitral, the Lady Health Worker Program has agreed to do the same. And the project is due to be scaled up across another union council, which is Hunza and Astor in Gilgit-Baltistan, the remaining Chitral in Pakistan, as well as Badakhshan in Afghanistan. And we're also in talks with the government in Afghanistan to see how it can be integrated within the Department of Health. If anybody has any further questions, please feel free to reach me at momina.muzammil@aku.edu. Thank you.
Thanks, Dr. Momina. Yeah, a wonderful example of a digital innovation that has the potential to scale up, and in fact has been scaled up, or we're looking to scale up through the government channels, which is a success story. I look forward for questions and discussion, and another request to delegates to type in the questions in the question and answer section. So we go to the next speaker, Dr. Jessica Series. She is from PATH, and she will be speaking on the impact of a digital health intervention. Findings from a mixed methods evaluation from India. Yeah, Dr. Jessica.
Thank you so much, Dr. Praveen. Just to check with you that you can see my slides clearly and hear me fine. Yeah?
Yeah,
great.
This is perfect.
Thank you. And I'm very excited to follow on Dr. Momina's presentation because the audience will hear many similarities, and this is such a great opportunity, I think, for learning between these projects and between other digital health interventions to strengthen primary health care. So our project, so what I'll be talking about today is community-led video education, which I'll explain in a bit, to increase vaccination coverage in rural Uttar Pradesh, India. And these are findings from a cluster randomized control trial. And thanks to my team of colleagues for this work. So let me just see if I can progress here. Okay, so sorry, just moving some things on my screen. Our project originally started, and this evaluation originally started to address the low rate or proportion of children in rural Uttar Pradesh who are immunized with all vaccines for their age group. So for example, in our baseline survey in 2016, we identified that 53% of 1-year-olds were fully vaccinated with the vaccines that are in the routine national schedule. So just more than half of children, and of course it should be closer to universal coverage to 100% of children. This figure was fairly common at the time. We were working in 2 districts in Uttar Pradesh, but this was common, kind of the median figure for Uttar Pradesh in general. And so this is also very compelling as it pertains to primary health care for a few different reasons. Immunization services, of course, are a really foundational service within a package of comprehensive primary health care. In India, particularly in rural parts of India, immunization services are delivered at village health and nutrition days. So those are outreach services in villages themselves, delivered by the auxiliary nurse midwife, who is a nurse and who is a key provider of primary healthcare services. So in India, immunization and other primary healthcare services are brought very close to people. There's been intensive investment, particularly in routine immunization services within the Village Health and Nutrition Day platform, and yet we still are only able to reach 53% of children. So this is, of course, very concerning. And our project aimed to identify an intervention that could potentially increase immunization coverage quite significantly, using a variety of mechanisms, and then to evaluate that in a rigorous evaluation design. So the intervention that that existed, but that we wanted to kind of implement with high fidelity, but also then evaluate in a real world evaluation context, is something called projecting health. So the basis, or the kind of the core component of projecting health, is locally community developed videos. So these are videos on different health topics that feature local women, typically from a women's group meeting, and the ASHAs, which is kind of like the community health worker in India. And they are developed by local community-based organizations on little cameras and screened in women's group meetings on these small projectors. So you can see in this picture here, women are sitting in the women's group meeting, and a small projector is screening a health promotion video. So this is kind of the central core of the intervention, but we also recognized that screening these videos alone, the hypothesis being that they may change behaviors and desire to seek immunization services, was probably not enough. And so particularly throughout the deep kind of qualitative informative research we did at the start, and then ongoing prospective process evaluation, we did realize that there were other intervention components that were absolutely necessary. So including strengthening the capacities and skills and motivation of ASHAs, also engaging hard to reach communities. So this is a term for communities in Uttar Pradesh that may not be geographically far, but may be socially isolated. They may face access barriers related to religion or caste or other factors. And so these were some of the elements that were really important in designing the intervention. So just to note here, some of the mechanisms or hypotheses that we had in terms of how the overall package of intervention components would improve the coverage of immunization and PHC services. There's a growing body of literature on the role of community engagement in strengthening coverage of primary healthcare services. So that's where kind of the community developed videos come in. There's also a growing body of literature on the importance of social networks and interpersonal relationships on strengthening access to and utilization of primary healthcare services, as well as the importance of motivation of the healthcare providers themselves. And so in this case, the community health workers and nurses, but mostly the ASHA community health workers, not only were we trying to build their skills, but also trying to motivate them. And as you'll see later, similar to what Dr. Momina said, they were very motivated by this approach and felt a sense of pride and ownership in this. Finally, targeted outreach or bringing services closer to communities is incredibly important, and tailoring how we do that is incredibly important for achieving effective coverage of primary healthcare services. And so you'll also see these hard to reach communities initially had not been targeted, activities had not been tailored towards their needs, but understanding their needs and how to reach them was very important. So essentially, we wanted to understand the impact and cost effectiveness of this community-led video education intervention on improving vaccination coverage. We measured fully immunized coverage amongst infants in these communities, including other aspects of other indicators for immunization coverage. So timeliness, dropout of DTP1 and OPV. This was a cluster randomized controlled trial. We included a total of 74 ASHAs and their surrounding villages and other kind of hamlets and communities that they were responsible for. And they were randomly assigned to either be a part of the intervention or not, to kind of be a part of the status quo. We performed cross-sectional baseline and end-line household surveys, estimating the impact using a difference in difference estimator. And I think one of the most important points in this evaluation is that we did this prospective process evaluation throughout the entire process. We were constantly iterating our own evaluation theory of change. We were constantly kind of recording the context of what was happening, why it was happening, so that at the end, we wouldn't just be able to say what happened, but really explain why and be able to refine the intervention and other approaches based on that. So skipping now to the findings, and so this is the what, not so much the why. We'll get to the why in a minute. We did find that the proportion of children who were fully immunized, so that's a fully immunized child, FIC, they did increase over time between baseline and end line, and this was a 2-year period. But they increased both in intervention and control communities. And the difference between intervention and control is not statistically significant. So you can see that on the graph here. But amongst families and children in hard to reach areas, so the most vulnerable communities, the intervention did statistically significantly improve vaccination coverage there. And it was actually, you can see quite a large increase in the intervention, which is the red dots, compared to the control, which kind of stayed flat in between baseline and end line. And so not only did it increase fully immunized the proportion of fully immunized children by 22 percentage points, but it also decreased the probability of DTP dropout by 9.7 percentage points and decreased the probability of OPV dropout by 13.8 percentage points. So these are quite exciting results. And so now I want to talk a little bit about why we saw what we did see and what that means for primary healthcare and policy recommendations overall. So starting with that exciting result of why did the intervention have impact among the hard to reach populations and hard to reach communities? Well, we think, and this is from, again, the process evaluation components and kind of many interviews with those families and with ASHAs and other stakeholders, that this was largely a product of increased outreach of the ASHAs to these hard to reach communities. So what we learned through this evaluation is that in these communities, families rely on ASHAs to tell them when the village health and nutrition days are occurring, to say, okay, it's happening tomorrow, please come. And also to explain to them in general that their child needs to be vaccinated and is due for another vaccine. So one really compelling insight that we had at our baseline survey was that 97% of families in these hard to reach communities reported that they wanted their children to be fully immunized. And so that, of course, is greatly different than the 53% that we see, or in those hard to reach communities, the baseline rate of fully immunized child was much lower than 53%. But yet all parents were saying, we want our children to be vaccinated. But mothers were saying things like, but my child was vaccinated when they were born. I didn't know they needed more vaccines. And the ASHA never comes here to this hamlet, so this kind of small community outside of the village. And the ASHAs would then say, well, we don't really know what to talk about in these communities. These are different kind of social community than our community in the main village. And so what we found is that the videos actually gave the Ashas a platform and something to talk about with those women. And so the women and the families living in the hard to reach communities often did not come to the main mothers group meetings to watch the videos, but instead the Asha would go to them and have a smaller screening in that hamlet, or would actually just show the video on their mobile phone in the household, for example. And it was just a way for the Asha to engage in conversation and to build a relationship, kind of that initial aid to help with that. And so this kind of basic linkage of the Asha to these communities seemed to have had a very great effect ultimately in being able to provide the very just operational information on where to go and when to go for the village health and nutrition days. So we were also very curious, though, why did the intervention not have a statistically significant impact among the full population? So through our process evaluation, one really important insight that we uncovered was related to gender. So we did do a lot of work, as Dr. Momina said as well, related to gender and women's empowerment and decision-making and family decision-making. And we found and we confirmed what other research says from this area of India, that decision-making around vaccination is not the mother's choice alone. It is a familial choice. Our intervention primarily targeted women, so mothers of infants. That said, we did also screen videos in community settings for men as well. And we also tried to reach mothers-in-law. But we often didn't tailor the messages specifically to the husbands or the mothers-in-law, right? And so I think we learned that we should have done much more testing of the messages with those other decision makers, and also kind of much more intervention around familial or co-decision making towards vaccination. And just to kind of note that the beliefs were never really kind of anti-vaccine sentiment, right? It tended to have more to do with factors like time poverty. So in households where the mother of the child was so busy with so many tasks, and where they had seen the child have side effects from vaccines, like a bit of fever, crying, fussiness, the family as a whole tended to just be a bit hesitant, specifically about returning for additional vaccines, when it felt like that was kind of a big chunk of time out of the mother's day, and then into the next day caring for a fussy child. So this also relates to quality of service provision. Another observation we made is that the vaccinators, the ANMs, are meant to give paracetamol at the vaccine visit to mothers and to the infants to ease some of those common side effects. But they didn't have paracetamol. So that budget line had been cut from the district budget, and they were not able to provide that paracetamol, which was a simple kind of quality of care thing that could help improve or decrease dropout if children were less unhappy. You can see my own child who's been vaccinated probably in the background. Okay, so another question we had, or another hypothesis of why the intervention didn't have the full impact was because we designed a multi-component intervention, but ultimately it did not address all of the health system's constraints, and particularly all of those quality of care constraints that I mentioned before. So unfortunately, some of the vaccinators working in these communities have not had supportive supervision. They've not had on-the-job training, and their practices are suboptimal, quite frankly, and it turns parents away. And I think if you're taking your child for vaccination or for any visit to health services or for primary health care, then you are going to make a rational decision to kind of protect your child in that moment. For example, if the vaccinator doesn't seem to be doing it safely, or if your child is suffering from fever and side effects because there wasn't paracetamol or anything to help them. So some conclusions. Interventions to improve service coverage must holistically address all drivers of coverage. So our intervention focused on a set of drivers of effective coverage, But we would have wanted and we will want in the future to address many more of the supply side factors as well. And digital health interventions, I think this is a very important conclusion for primary health care, can be pro-equity. So we found in our study that the digital health intervention had more of an impact amongst the most vulnerable populations and hardest to reach populations, but steps should also be taken to address the underlying causes of unequal service access, availability, and quality. So this was a tool, right, in improving the access and utilization of primary healthcare services, but there are some underlying systemic factors that constrain access and utilization amongst the most vulnerable populations. So in conclusion, thank you very much, and looking forward to any questions you may have. Thank you.
Thanks, Jessica. This was a wonderful talk. So now, can I request all the speakers to come online? Maybe switch on your videos. Yeah, okay. So, yeah, I mean, it's an interesting mix that we have seen here. Dr. Berhanu talked of an intervention and innovation that affected mainly, if I can say, the health system. That is the supply side. Whereas Momina and Jessica discussed about innovations that affected. Well, Momina described an innovation that described the demand side. Which caused an increase in healthcare access. Whereas Jessica, the videos, it's wonderful to hear, how it affected at all the three levels, at the level of the providers, at the level of the receivers, and how it increased the linkages between both of them. So a mix of, the supply and the demand sort of thing. So before we go to the questions, Berhanu, I have some questions for you. So I was just wondering, we looked at capacity and performance of the health workers and the health system status and response. I'm just wondering, before the CNBC program was sort of introduced, was there anything done in relation to the health worker preferences, in understanding what the preferences were and where those sort of included in the program?
Sure. So I think, so when the health extension workers started, their primary roles was more prevention and health promotion rather than curative services. So the community-based work care program added to that package of work that they do. But prior to that, the integrated community case management had trained them to provide services to 259-month-old children. So some of the quantitative data showed that that kind of sort of increased their acceptance and their sort of skills and made them more acceptable in the community. So in that sense, it was something, that kind of services was something that they were interested in, eager in, but though specifically, I would not say that their preferences was assessed for that particular intervention, but other data show that they were always happy to have more of a curative service skills provided to them.
Okay. And just a follow-up question on that. We saw there is an increase in health system response, but the softer sort of factors that are responsible for this health system response. So what do you think were the main influences for the improvement in health system response?
Can you repeat what I didn't quite catch?
Yeah. So you did describe that there was a health system increase in health system response.
Yes.
I was wondering what were the main influences? What factors influenced this increase in the response?
Sure. So I think for community-based newborn care program to be implemented, there was a lot of stakeholders that were involved that were outside the government of Ethiopia. So we had Save the Children, UNICEF, etc. So there was a lot of initial response to get some of the drugs out, some of the supervision out there that were not necessarily even part of the health system. So there was that initial push. So by the time you get to the follow-up survey in 2017, some of the reasons you don't see those drugs being as available as you would is some of that stakeholder support was no longer there and the system didn't quite the system wasn't quite able to take on those responsibilities, so ownership. So some of it is also part of that stakeholder coming together to support this program and make sure it's up and running.
Right. Thanks, Berano. So Momina, I mean, now over to you. So, I mean, I didn't get a sense of the scale of this program that you sort of implemented in Pakistan and Afghanistan. So, was it some districts? Was it the entire states, or?
Yes, I'm sorry. I probably should have put in a slide about that. So basically, it was implemented in around 17 UCs in Pakistan, so 17 union councils, and 6 in Afghanistan. There's so select UCs in Gilgit-Baltistan and Khyber Pakhtunkhwa. They're both in the northern part of Pakistan, so very hard to access. And then, but it's currently being scaled up in. So it's being scaled up across the remaining Chitral, and so all of the UCs in the district Chitral will be covered, which is in Khyber Pakhtunkhwa, and then in Afghanistan, it's being it was implemented in 6 UCs, like I said, in Bamiyan and Badakhshan provinces, but now it's going to be scaled up across Badakhshan.
Wonderful. So now, so as we usually see with this sort of mobile health technologies and digital interventions, so there are complex numbers of factors that influences the uptake of such a program. It's wonderful that I mean, such a program was shown as to be positive and is being scaled up currently. But I'm keen to understand, was along with the implementation of this particular digital innovation, was there any other system-based changes, that were sort of addressed or made to make it suitable to the digital intervention?
So system level changes, we're hoping to influence policy as a result of this project, and we're hoping more digital health interventions are taken up, and then the government is hopeful. And I think the one thing that really did work was just continuous coordination. So we made the government stakeholders felt like it was their project. We got them involved from the start. The implementation teams felt like, so they were taking a lot of ownership. The health workers were taking a lot of ownership. And I think that's the one thing that really worked. But as far as any system level changes that we can see, apart from the integration and the fact that they're using the intervention now, and that they've absorbed it into their budget, or they're planning to do so, we don't really have any other thing to show for it at the moment.
Okay. And was there any economic evaluation done for this, or are you planning to do
no, that? Not yet, but we're hoping to work on that as well.
Okay. Thanks, Mumina. So, Jessica, wonderful program again here. And as I said, it's a mix, trying to increase the demand and increasing the supply. But when it comes to vaccination, it's really complex. One, as you said, increasing the awareness of the mothers is one, influencing other family members who are the decision makers is two, and also providing the infrastructure, asking ourselves, the frontline health workers, to go to the community, more interactions, have the trust belief model. Those are very interesting factors here, and I feel the video is one channel that actually did not. I mean, it actually influenced that. It might not be the main cause, but it actually made that these things happen. But when we talk of and of course 45 to 65% of improvement, I think this is remarkable. What I couldn't understand is, are there any other factors for not taking vaccines? Say, for example, the vaccinations are taken at a health facility. and so the distance of the village or the house, the loss of daily wage to go and get themselves vaccinated, get child vaccinated. So are these some of the issues, or did you face any other similar kind of issues that you think might have influenced the uptake of vaccination and need to be addressed?
Yeah, thank you. It's a great question. In this particular context, because the Village Health and Nutrition Day exists and vaccinations are brought to the village, there are fewer geographic access barriers, right, than in other contexts where the mother has to travel to a health facility. And so for that reason, we've thought a lot about kind of replicability in other contexts, and noting that this package of interventions doesn't address that distance factor that is so important in other contexts. So that is another reason. And but yeah, as you said, Dr. Praveen, the reasons for under-immunization are so complex, right? And you also pointed out that this intervention is kind of just one tool. And I think one of the risks when we think about innovations in primary healthcare is that we don't over-index on these shiny, innovative tools like this, right? Because ultimately, we have to understand what it is addressing and how it is working. And in this case, it's really about how can we motivate the ASHAs to engage with these communities. We found that if that was the mechanism by which this intervention worked, it might not need to be a video, right? It could potentially be a better paper-based job aid, which would be much less expensive to replicate, that the ASHAs take, or it could be better supportive supervision for the ASHA, right, to do that outreach. And so I think one thing that we learned when we disseminated this to the state level audiences, and then also even the district level, is that everyone was so excited by the videos. They said, great, we'll show these videos on TV, we'll put them in the train stations, we'll put these videos everywhere. And I think there's a concern there of like, okay, but it might not be the videos, right? And we have to understand why parents are not able to vaccinate their children and address those causes really directly. And it could be a whole mix of interventions then that we bring to bear on that. So that's just kind of a thought in terms of what we call innovations in primary healthcare. Thanks.
True. Thanks, Jessica. So I have a couple of questions from Patrice here. So to Berhanu, are the HEW-TBA of the same as community health workers?
So the health extension workers are part of the health system. They're salaried. Community health workers, but and consistently they have a 10th grade education, and then they're trained for 1 year in the different packages of the health extension program. So yeah, so that's how they're different.
So they are the frontline health workers.
Exactly.
Okay. Yeah. But they are under the government payroll or
exactly.
the government services.
Yes.
Okay.
Yeah.
Okay. And yeah, you have another question from Mary. So was there any monitoring of the health officers' diagnosis? So Mary refers to a study in Zanzibar where they found only 24% of health workers were providing treatment according to IMCI or adult treatment guidelines. And she was keen to understand what the gold standard that was being used to measure the community worker diagnosis against.
Yes, this was also of concern for us. So what we tried to do in trying to ensure that they did serve as gold standards was that we only included the re-examiners that had already been trained in integrated community case management, of which this possible sepsis management is a part of. So most of them had served as training of trainers throughout the health system. And also as part of the training for data collection, we'd blocked a couple of days to go through the chart booklet or like the treatment algorithm so that they're following it correctly. It also included a pilot study where we also observed how they were that they were following the guidelines. So we recognize that this of course could be a limitation, but we tried our best to at least ensure that they were serving to the best of their abilities as gold standards.
Okay. And Momina, Patricia has a question for you. Can you please give more details on the methods you used in creating demand for service?
Yes, that's a good question. So basically, there were two main things that we did. One is the awareness content that was incorporated in the mobile applications. And I think we were very pleased to get some feedback where they requested. So initially, it was just basic MNCH thematic videos regarding antenatal care, postnatal care, deliveries, things like that. But then we had people come in asking for more videos or more information regarding, let's say, postpartum depression, and then regarding NCDs and depression in general, other mental health issues. So I think that really set the stage. Once they felt like they had a reliable source of information coming in, they were asking questions. And then apart from that, we were also disseminating messages regularly to consumers who were registered in the application. So they'd have periodic messages on a range of MNCH themes going out. Oh, Dr. Praveen, I think you're on mute.
Yeah, I'm sorry. Thanks, Movina. Yeah, that was wonderful. I don't think I can see any questions from any members, audience, but uh, Jessica, one final question to you. So if you get a chance, what modifications or what sort of improvements would you want to make in the intervention?
Great question. And something that we were always thinking about, and I think it's important to always be thinking about, even in the context of an evaluation. We would put much more emphasis on those supply side challenges and work much more closely with the A&Ms and their supervisors to make sure that they are supported to have the skills and practices that they need to deliver high quality services, because that seems to be such a major barrier, particularly when it comes to vaccine dropout, right? And the choice of families to not, or to either the choice to not go back or not being able to go back because of the various constraints. So yes, I think much more emphasis on the quality of providers and kind of everything that comes with that delivery of services would be our major focus. And then the other thing that I also mentioned was doing much more testing of our messages with fathers and other family members to ensure that we're not just changing the desire to vaccinate amongst mothers, but to all of the decision makers in the family.
Right. So would it be all right to say that you would not be looking at one single video sort of intervention, but you would be looking at package where you are sort of addressing the health system, you know, the A&M's capacity, the interface, and all of those sort of things?
Exactly. Yeah.
Okay.
I think we're learning in immunization and primary healthcare, you know, just generally, that the packages of interventions and strategies that we undertake have to be so comprehensive and multi-component and holistic to address all of the barriers to accessing high quality primary healthcare.
True. Wonderful. So I'm just opening this to all of you. So if any of you have any questions to ask to any of the speakers here.
Nothing, but it was a pleasure presenting with both of you and Dr. Praveen. I think the work you're doing is absolutely amazing, and I especially loved how it's funny how I'd never come across your work, but I feel like our projects are quite overlapping, so I'd love to read more about it.
Agree.
Wonderful. Good. So thanks. It was wonderful interacting with all of you, and I thank the audience and the questions that were raised and the discussion that this generated. I look forward for more questions that could be possibly said with all of us. Thank you very much again to all the three great speakers. It was wonderful hearing about your projects, and I wish you all success in the future. Thank you very much.
Thank you.
Thank you very much.
Bye.
Thank you. Bye.
Bye.